Very recently, and I'm meaning the last year or two, there's been information coming out in the scientific circles of gene therapy. That's probably the way to go. If we can find some sort of treatment that is a once-off, or maybe once every year, or 2 years, or 5, then that would change the game.
Good morning, everyone. So today I have Dr. Jonathan Burdon with me today, who has very kindly given his time to speak to us. So thank you so much, Dr. Burdon, for being here. For those of you who don't know, Dr. Jonathan Burdon, he is a specialist respiratory and a sleep physician. And amongst his many achievements, he's also a global expert in respiratory disease as well as Alpha-1 Antitrypsin. Among his many achievements, he has been chairman of the Australian Lung Foundation as well as president of the Australian Thoracic Society of Australia and New Zealand. And I think what I admire about him more than anything else is that he has been a great advocate for his patients. So thank you so much, Dr. Burdon, for your time.
It's a pleasure, and welcome everybody, and I look forward to talking to you.
Can you please discuss how Alpha-1 antitrypsin impacts on the lives of your patients?
I think early on, it doesn't impact them at all because there's been no damage done to the lung or elsewhere. And of course, I'm a lung physician, so that's largely what I do. If I see people who've got other manifestations or the rarer manifestations of Alpha-1, then I farm them off to, it's usually the liver people, but it can be elsewhere. But the main symptoms are people start getting a bit short of breath on exercise. And this is something that creeps up on you because the lungs built with a lot of, let's say, reserve capacity. So unless you're running around all the time at high speed, you don't use up the top bit of your reserve capacity, so you don't know until such time as it's eaten into a fair bit of it, and then you start noticing that you're getting short of breath, and that's usually the first thing that people present with, and they go to their doctors saying, well, I'm short of breath, and then they go through the trials and tribulations of being investigated, and I think general practitioners are more aware of Alpha-1 antitrypsin related lung disease now than they were perhaps when I started out in this game. It's people may be sent for lung function tests, and often the chest x-rays first up. And we see the characteristic changes of some early on, it's emphysema in the lower part of the lungs. And then the patient gets accused of, well, it's all due to your smoking. And of course, it may be contributed to smoking, but of course, Alpha-1's got nothing to do with smoking. It's made worse by smoking simply because you've got the Alpha-1 problem and you've got the smoking problem. So one plus makes two, sort of thing. So it's shortness of breath, occasionally coughing, and that's really the main thing that we start with, and then that progresses with time. Such that you just get progressively more short of breath until you're very breath and short of breath at rest. And those are the sort of the common sort of things. And usually people present for the first time in their 40s, 50s. That's the sort of time. I've seen someone present at the young age of 19. And occasionally we see people in their 60s or 70s are coming along for the first time, a bit short of breath. So there's a bit of a spectrum about how rapidly it progresses in individuals.
Yeah, how interesting. And I think as a medical professional, that's one of the challenges because the symptoms are so non-specific. So shortness of breath, and Alpha-1 antitrypsin is a rare disease in our community. So I guess having that suspicion, so what would make you suspect that a patient might have Alpha-1 antitrypsin deficiency?
Well, certainly the commonest thing to make you sort of jump out is someone coming along with shortness of breath on exertion, who, I mean, I would always think it's in my list, if you like.
Yes,
But then, of course, I'm sensitized to this because I've had a long interest in it. But The usual thing is you'll get a chest X-ray, and then you'll see those chronic airway obstruction changes on the X-ray. And I think then the question, of course, is, are you smoking? And the next question after that is, what do you do for a living? So if you're, for example, a miner or work in a chemical factory, or you're inhaling fumes or dusts, then the treating doctor might start saying, well, it's due to that. And or sometimes they, and more frequently, I must admit, general practitioners and others are thinking, well, could this be Alpha-1 antitrypsin deficiency? And along with the blood tests we send off, because we'll be checking for things like thyroid disease and those sort of things, we just add Alpha-1 antitrypsin concentration on, and you get a surprise once in a while. And so, as you say, this condition is not common. We think probably in Australia, one person in every 5,500 live births has the ZZ type of antitrypsin. And that's based on overseas figures, because we haven't done a survey in this country.
Wow. Yeah.
One of the issues here is that the frequency of the condition varies between different ethnic groups. So, for example, Southeast Asian peoples have a much lower frequency. Middle Eastern people have a much lower frequency. So we're very fortunate here in Oz. So we've got a big mixture, and it's sort of been fantastic. But of course, when it comes to doing this sort of thing, then I know some of the figures have just been based on Caucasian populations, but I've tried to work out, where the percentage of the populations come from, and try and work from that. But we're looking at about one in every roughly 5,000 live births for ZZ deficiency.
Excellent. So what are some of the investigations of choice that are currently used to monitor disease progression in Alpha-1 antitrypsin disease?
In terms of monitoring, we would lung function testing. Now, and some doctors would do that every year or every 2 or 3 years, something like that. The problem with most people with Alpha-1 antitrypsin deficiency is that the decline in lung function is slow. And in a way, that's really good, but you don't want it to be quick. It's not great either. But it takes us to clinical trials, because the decline in lung function is slow. It takes us a long time to measure a difference. And so I tend to do lung function every 2 or 3 years, something like, or every couple of years, something like that. A lot of the patients I see are in clinical trials anyway, so they're getting them done much more frequently than that. So lung function testing, and that would be spirometry. That's where we get you to take a big breath in and blow out as hard as you can, and we yell and scream and tell you you're not doing it hard enough and all those sorts of things. And a second test called the diffusing capacity. And that's where we ask you to hold your breath for about 10 seconds. And it's a test which, the best way of looking at it is to think about it as a measure of how difficult it is to get oxygen into the blood through the lung. So that'd be so lung function testing is the sort of, if you like, the first thing. The second thing is we would do high resolution CT scans. Because of the fact that the condition for most people progresses slowly, we would probably do those once in a while, every 2, 3, 4 years, something like that, and probably less frequently in a non-clinical trial environment. Clinical trial environment's a bit different. And again, we can get some idea about changes, but CT scans, like any picture, its beauty is in the eye of the beholder, if you like. And some radiologists are usually very good at these sort of things, but I wouldn't necessarily agree that I agree with everything they say, and I'm not a radiologist, and I don't know how they see some of these tiny little nodules, because even when they point them out to me, I can't see them. So that's but on the other hand, people say when I'm listening to chest, I can hear things that other people can't hear. So maybe tuned, So, but lung function, but a CT scan should be done, once in a while. We don't do them too frequently, because even today, when we have low radiation exposure, it still adds up over the years if you do too many. I always operate on the principle and teach that if you're doing a CT scan, there should be a good reason for doing it. And surveillance may be a good reason, but you really got to be sure about what you're doing there. So those are the two things that you do for following. Now, many people listening to this talk will wonder about lung density. Now, lung density was a measure of lung function, if you like, or lung pathology that has been used for quite a number of years, but was used in the UNWRAPPED trial, which we published in 2015, as a more sensitive measure of lung tissue loss. And it certainly is. There's no question about that, in my view. And in the UNWRAPPED trial, we showed that there was a clear loss of and statistically significant loss of lung density over the 2 years of the first half of the trial, when people were either getting replacement product or not, in a double-blind situation. And then in mid-trial, everybody got it, and we could just see the differences. And so I think lung density is something that may come in the future. It's not readily available at the moment. And in the clinical trial situation, we had to send the CTs on CD-ROMs to Scandinavia, I think, as I remember. It's a long time ago now. But so that's something else, I think, on the horizon.
Excellent. What are some of the treatments that patients with Alpha-1 antitrypsin can access to slow down disease progression?
Well, I think there's a number of sort of standard things, and these have been thrown back at us by the government when we tried to get augmentation therapy funded. And I think, as listeners will know, it's been approved for use in this country. So prior to that, we had to get special permission for the odd person who could sell. As I think people will know, it's you're looking at $80,000 to $100,000 a year, and it's not just for this year; it's for every year. And I've been asked once in a while, why don't I do it for a year? Doing it for a year is a waste of time, basically. Anyway, so what can people do? Well, first of all, it's about good lung health. So you should avoid doing things that may interfere with lung health. And of course, I'm back on smoking, and so avoid cigarette smoking, and that includes vaping. I've just been talking a week or so ago about vaping. And avoid being involved in polluted environments. So that if you work in a polluted environment, I suggest you move your job to a non-polluted environment. Don't work down the mines or in a dirty chemical factory, or those sort of things. Should you work there? Well, I would say yes, but providing your respiratory system is protected, and that usually means some very careful equipment, to be not just the ordinary paper mask. That's not going to help you. So it's about not smoking, not getting involved in pollution. It's about sensible lifestyle in terms of rest, diet, all the things our mothers told us to do. Those sort of things. So the next thing is, if you get a respiratory tract infection, get it treated promptly, because respiratory infections can damage the lungs sometimes, and alpha-1s don't need damage added to the mix. And I would suggest that anybody with alpha-1 antitrypsin establishes a good relationship with their general practitioner, and that they should all be seen at least once by a respiratory specialist. And they may say, come back in 5 years or something like that, or let your own doctor look after you, but I'm here when and if you need me, sort of thing.
Absolutely.
So those are the things that we can do that are outside the more, let's say, augmentation therapy and other things that are coming on the horizon.
You touched briefly on how augmentation therapy is quite expensive and out of reach of most people, $100,000 a year. Most Australians don't have that sort of money. Would you like to just touch on what your thoughts are about that?
Well, I think there's two parts to that question. One is about augmentation therapy and the other is about the cost. But augmentation therapy clearly works. Now, I know Thoracic Society has published a position paper, in which when it came to discussing augmentation therapy, they said, and I quote, augmentation therapy could be considered by the specialist. My view is it should have said should be considered by the specialist, and it's not saying anything out of school because it's written in the paper. That based on that, I withdrew my authorship of the paper because live with myself or look alphas in the eye when maybe we might do it. But augmentation therapy clearly works, and it is used all around the world. I think Britain's probably the only place that it's not funded, and I know I've seen a recent paper that will eventually go to publication, coming from a European group that has looked at what all the countries do about augmentation therapy, and Britain and Australia, I think, are the only two. Maybe there's another one that are not funding it. I think that's very sad. I can understand the cost. The argument is that, well, you do all the things like not smoking and all those sort of things, and cost benefit analysis, all those sort of things. Well, my view is there is evidence for people living longer if they're treated, and those sort of, well, I'm just a humble chest doctor. I would have thought that means you can pay more taxes and contribute to the community and family and friends and all those sort of things, and I think that's important. But anyway, it is what it is. In terms of cost, there is no way of getting the cost down for somebody. I mean, if it's not, then it's the government. And a lot of effort's been put into to establishing that it does work, at least at the evidence that there is there now. And the RAPPED trial was the first time it was really established on a double-blind, multi-center national study. But there are quite a number of other studies that have shown it works. It's just not with quite the same rigor. And I think the negative people will say, well, we need another couple of trials like that. Well, 5-year trials are very expensive and are not going to happen again. Now, I do see, I'm aware that there are ongoing trials of augmentation therapy looking at different things like single dose versus double dose and those sort of things. Those trials, when they're complete, will assist in adding evidence to the side of the equation that says, yeah, it works, and that sort of stuff. And so it's a problem.
Yeah, and it is hard for patients with Alpha-1 antitrypsin deficiency, knowing that there is a treatment out there, but unfortunately,
not for you.
Yeah, exactly. Yeah, very sad situation. So that leads me to my next question about emerging therapies. A lot of other diseases have biologicals and small molecule inhibitors employed to treat inflammation. Is that the case for Alpha-1 antitrypsin deficiency as well?
Yes, if very recently, and I'm meaning the last year or two, there's been information coming out in the not so much in the media, but in the scientific circles of gene therapy, and I think that's probably the way to go. It's you see, one of the things about augmentation therapy is we're saying you need to come in once a week or once a fortnight infusion, and we looked at, or some years ago, inhaled therapy was looked at, and that didn't really work very well. But if we can find some sort of treatment that is a once-off, or maybe once every year, or 2 years, or 5, then that would change the game. So I am aware of a study that is being contemplated. Probably won't get as far as getting started for at least a year or two, looking at gene therapy. And I understand that's basically you have an injection, and I'm not a gene therapist, so I don't quite know what it's all about and how it works exactly. But what it does is it manipulates the genetics of the liver cells such that they produce normal Alpha-1 antitrypsin, that MMs, and we think that probably we don't know whether it's going to change all the cells or some of them, and I think the plan would be that it's an infusion which takes about 4 hours, I believe. I understand that there are some rats that have been tested, so it's looking good, sort of thing. And my understanding from what I'm reading is that this will last, well, they're not sure, a few years, if not longer. That's all to be seen. And it's a watch this space. So if that comes to fruition, I think that'll be a huge step forward. And it's what the cost is. I have absolutely no idea at this stage, but it would be attractive to everybody, I'm sure, rather than having to have your infusions once a week or once a fortnight. Even if it's worked out to be once a year, it would be anyway. That's a very much watch this space.
Sure. An inhaled Alpha-1 antitrypsin, is there a lot of evidence for that?
Sorry, which?
Inhaled Alpha-1 antitrypsin therapy.
No, that's largely been discounted.
Okay.
There's a few problems with that. It didn't seem to work. Secondly, I've sort of, it would have to be twice a day. And if you're like me, I tend to forget that little pill I've got to take at night.
Yeah.
And so it's that would need to be, you need to be very fussy about that. And it doesn't. We would be using it now if it was working.
Okay. That probably brings me to the next question about clinical trials. About anything, just any new exciting things happening in the Alpha-1 antitrypsin space?
There's a few trials underway. I've already mentioned looking at single versus double dose.
The
trial that I'm aware of, but not all the details, looking at liver changes rather than respiratory things. And then over the horizon, not on the horizon, over the horizon, are potentially gene therapy trials.
Excellent. How does a patient with Alpha-1 antitrypsin navigate being prescribed home oxygen therapy?
The usual thing is your general practitioner will refer you to a respiratory physician. Or you might be seeing another doctor for some reason. Anyway, you'll end up with a respiratory physician, and then the respiratory physician will look at this carefully. You would be, mostly when we see people in the rooms, we get to put the little finger oximeter on and see oxygen saturation is. And we know that supplemental oxygen at home at government expense, you've got to fulfill a number of criteria. And one of them is that your oxygen level's got to be less than 55 millimeters of mercury, which you're going to be very short of breath there and a bit blue around the gills when you walk in the door. So there's an association between saturation. Saturation just means the amount of oxygen that's actually binding to the hemoglobin in the blood compared to how much you could get onto the hemoglobin. So if your saturation is 90%, that means there's another 10% capacity there that could have picked up some oxygen on the way through. And there's a relationship between saturation and oxygen tension. That saturation of 90% is equivalent roughly to a arterial oxygen tension of 60 millimeters of mercury. And when they first started the government program many years ago, that was the cutoff. It's now down to 55, I think. So basically, you need to be very short of breath. Your doctor needs to send you off for these tests. And sometimes the oxygen level is reasonably well maintained. So let's just say it was 62 or 3, so you just don't quite make it there. But we might then send you off for an echocardiogram and measure the pulmonary artery pressure. That's the artery that leads from the right-hand side of the heart up to the lungs. And if your lungs are not working terribly well, and you know that alpha-1 causes emphysema, which is loss of lung tissue, so the blood can't get through. I'm being simplistic here to make the point. Can't get through the lungs as easily. It's a bit like a sieve in your kitchen. Some of the holes are blocked up. So the blood banks up and the pressure in the pulmonary artery rises. And if we can show that you've got an elevated pulmonary artery pressure, that's another trigger for getting some oxygen. You've got to be pretty short of breath, I'm afraid. And, what else can we do? I didn't mention early on, we do try all sorts of inhaled medication, and we find that sometimes works. And I should have mentioned that earlier on after talking about, don't smoke and all that, but that's the main thing. It's clinical experience shows that some of the anticholinergics are helpful. Ventolin, salbutamol is sometimes helpful, but these are not. We'll take you through it all, and my attitude has always been if I can get a 5% improvement for you with this, maybe I can get 5% over there. That's 10%. It all works. So this is a matter of, to some extent, trial and error. Bit different to something like asthma, where we know that it's like salbutamol, Ventolin, or the other bronchodilators actually do work, and it's not loss of lung tissue. That's about muscle spasm.
Absolutely. Finally, when would a patient with alpha-1 antitrypsin, when would they be considered for lung transplantation?
Well, first of all, they need to have severe lung disease, and your oxygen level would need to be well below or in the range where we would be getting you supplemental oxygen at home. And in that situation, I think at about that time we start thinking about it, and even before, it's when people are clearly hypoxemic, that's hypoxic if you like, low oxygen, struggling with exercise and loss of activities during the day, needing more personal care, help at home, all those sort of things. So we tend to try and think about that earlier, and to some extent there's also about how frail are you,
exactly.
How much help are you needing, and et cetera, et cetera. Those come into the mix. And then is make a time for you to see the transplant clinic at your hospital in Melbourne. It's the Alfred, and it's in Sydney and so forth. So and other places do them, of course, around the country.
Excellent. Thank you so much for your time, Dr. Burdon. It's been such a pleasure having you, and thank you for being an advocate for Alpha-1 Antitrypsin. It means a lot to us as an organization, but it also means so much to patients that unfortunately they feel so let down by the medical community, by specialists and by general practitioners alike. So hopefully that's something that we can work together to change over time.
Yeah, well, thank you. And I was pleased to be able to talk to everybody today. I feel a bit guilty that I haven't put enough work into this in the last year or two, but there's a whole lot of other things that have cropped up, including COVID and et cetera, and healthcare's under the pump. But I'm hoping, I'm trying to reorganize my life so I can Alpha-1 and augmentation therapy or gene therapy is on my bucket list. I need to get that ticked off before I head off.
Well, hopefully we can work together to do something like that.
Let's
okay.
Do it.
Thank you so much for your time. Much, much appreciated. Thank you.
Okay.
Bye.
Bye.
Bye.